The UK Lung Cancer Coalition is releasing a new report about genomic testing for lung cancer. This report is important because currently there are significant delays in the pathology and genomic medicine pathway. Now, why is this important? If we go back 20 years or so, historically we needed to know whether patients had small cell lung cancer or non-small cell lung cancer. Time moves forward, and within non-small cell lung cancer we had multiple different types: squamous cell lung cancer, adenocarcinoma, non-small cell lung cancer not otherwise specified. But now we need to profile non-small cell lung cancer at a genomic level in order to identify mutations on the cells of individual tumors. The reason for this is that we now have multiple treatments that we can offer patients targeted at specific mutations. Some of these treatments can only be given in the first line setting, so we have to know quickly what mutations patients have on their tumor before we can institute treatment. Now, lung cancer is a fast growing cancer. If we wait too long for that testing to happen, then patients can progress, tumors can get larger, their performance status can decline, and sometimes patients who were originally fit for treatment become unfit for treatment. Now, when a biopsy is taken, we first of all have to send it to the pathologist, and they do the initial immunohistochemistry on it and identify the type of lung cancer, and then it's sent to a genomic laboratory for the genomic panel testing to be done. Ideally, we'd like this done within 14 days, from the time of the biopsy to the time that the full report is available to the treating oncologist. But we know from anecdote around the country, and this is in England, Scotland, Wales and Northern Ireland, so across the whole of the UK, that these pathways are sometimes taking 4 or 6 weeks or more. And during this time, of course, patients are in limbo. They've been told they've got lung cancer, but they don't know what treatment they might be suitable for. And as I've just said, their overall condition might be deteriorating. So recognizing that this is a really significant problem, the UKLCC wanted to focus on it. Now, following a meeting we had with representatives from NHS England in 2023, it was agreed that we would aim towards a 14-day turnaround time. And also this is being largely adopted in Scotland and Wales and Northern Ireland as well. But the reality is we're not actually achieving this at the moment. So what we've done in this report is to break the pathway into 3 sections: pre-genomics, genomics and post-genomics. We've identified where the problems lie in each part of the pathway, whether the biopsies taken are suitable, how long it's taking for samples to get to the pathologist, how long the pathologists are taking to do their initial work on it, how long it's taking to get to the genomics laboratory, time delays in the genomic laboratory, and then getting the results out to clinicians in an understandable format. Some parts of the country, and in some countries, they're doing a really good job, and they've found local solutions to speed up various parts of the pathway. But as I said, in many places, things are running too slow. So what we've also done is, in this report, is shown a number of exemplars of best practice. For instance, in the southwest of England, coming up from Land's End, they put samples in courier vans and get them up to the genomic laboratory hub in Bristol within a day or so. In the northeast of England, the northeast genomic laboratory hub is generally getting their processing done within a week or so. In Glasgow, the pathologists and the genomic medicine teams are working very closely together to cut all the sections they need on the first day so that everyone's got enough material. So there are lots of solutions out there. So as I said, looking at the whole pathway over 14 days, we've made a number of recommendations, 12 recommendations in fact. I'm not going to go through all of them, but just to cover off a few of them. For instance, starting at the beginning, when chest physicians or interventional radiologists take the initial biopsy, they have to take good biopsies with adequate material, probably more material than we used to take in order to allow for all these extra tests. And we should also be auditing our outcomes so we know whether the biopsies we're taking are good quality or not. Because if you have to repeat biopsies on patients, of course that's a great inconvenience and source of worry for patients, and it puts a big delay loop into the whole process. You then need to invest in getting the samples quickly to the pathologist. The pathologist, we're saying, should try and turn around the samples within 4 working days. So we're saying that this should be 14 calendar days, the whole pathway, but really it's going to require the whole pathway working every day, weekends included. Once the samples have been processed and dealt with by the pathologist, they then got to be transferred to the genomic laboratory hub, which may be local or it may be at some distance, but again, they need to be moved quickly and efficiently. Hopefully samples being barcoded at the time of biopsy so they can be tracked all the way through the pathway, so we always know where the samples are. When they get to the genomic laboratory hub, we're saying that they should turn around the samples within 7 days, and the reports they issue need to be in a form that is readily understandable by the treating clinicians, because some of the reports are extremely difficult to understand. IT systems need to be joined up all the way through the pathway, and rather than a genomic report being issued and sent back to the pathologist to be incorporated with the full report, for instance, in the northeast of England, they have a system whereby they have a single mailbox where all the treating oncologists can see straight away reports as they come out off the system, and they can immediately get the data they want. So we believe that this can be achieved in 14 calendar days. It is going to require quite a lot of teamwork and investment across the whole pathway, everyone working together. It will require, suitable investment, workforce-wise, and in order to make it work, and training people, because there is a shortage of people in pathology laboratories and in genomic hubs. But in some places in Wales and Northern Ireland and Scotland, they have actually got very efficient pathways already working. So we know it can be done, and that is the challenge. And of course, if we can get these biopsies reported and all this information onto a treating oncologist's desk, it will mean that patients get their treatments much faster. We can treat more people. We're talking about probably, about 30,000 samples a year for lung cancer alone going through this pathway. So it's large numbers, but it means that a lot more people will potentially be eligible for treatment. And that will save lives, because we know that people treated with appropriately targeted therapies can live for months or years with good quality life.